I want to introduce a not quite so new, but clearly very distinguished faculty member, Dave Dawson, who, as you all know, has been instrumental in developing the vascular training programs that didn't exist here 5 years ago. It's really been a tremendous contribution to the educational program of the department. And today he's going to catch us up on important things about peripheral artery disease. And this first picture, at first I thought it was bacon and eggs, but maybe it is bacon and eggs in another way.
It is.
Dave.
Thank you, ma'am. All right. Well, thank you very much. Peripheral artery disease is actually a very broad topic, so I've broken this down into 6 half-hour segments. But I threw out about 5 of them. No, I actually, we'll run through quite a bit of stuff. No disclosures. But peripheral artery disease is highly prevalent. We're talking about 200 million people worldwide. And a lot of people say, well, I don't treat PAD patients in my practice, and those are people who are pediatricians. Because if you take care of adults and older adults, you will take care of patients with PAD, and about 1 in 5 over the age of 70 has peripheral artery disease. The prevalence of PAD is increasing, and studies suggest that it's increased by about 24% over the past decade. It's important, not just because of the symptoms and the problems that are caused by PAD, but it's associated with increased cardiovascular risk. It's also important because it's an expensive problem. Medicare spent about $9 billion for combined in- and outpatient care a decade ago. That's the most recent paper on this. And most of the costs are for the severe late-stage manifestations of limb ischemia. It turns out that early recognition of PAD by patients and clinicians can offer opportunities to reduce these costs and do more with preventative care. Atherosclerosis risk factor reduction, claudication treatments that are simple and inexpensive, durable revascularization interventions need to be evaluated as ways to reduce these costs. Well, what do you need to know? It kind of depends on who you are. So I'll talk about some things that are appropriate for you if you're a student. I'll talk about some things that are appropriate for you if you're a provider. And I'll talk to you about maybe a few things that you need to know as a vascular specialist, or at least give you some ideas of the tools that we're using now. You need to be able to recognize the disease. Can't do much if you can't make the diagnosis, and then appreciate the significance of that diagnosis. You may not be treating these patients in your surgical practice, but you need to understand the treatment options and you need to avoid errors. Most people with PAD are asymptomatic. Okay, just because you have atherosclerosis doesn't mean you have symptoms, but when patients present with symptoms, the most common symptom is exertional leg pain, but most are kind of atypical. Only 10 to 30% really have the classic symptoms, and only about 5% at 5 years progress to critical limb ischemia with tissue loss and gangrene. Okay. The classic symptoms are aching in the calves with exercise relieved by rest. Many patients, though, with proximal disease may have hip or thigh or buttock pain. But patients with severe ischemia at rest, resting ischemic pain, may have pain in the forefoot relieved by dependency, or there may just be fairly nonspecific symptoms of tiredness. Patients may present with wounds that don't heal or with infection. The clinical diagnosis is made by the doctor, provider who sees the patient. About a third of patients with symptoms don't communicate this to their physician. So it's important to have a review system that includes one simple question, and that's, how far can you walk? And if someone says, I can walk without any problems, that's a negative review of systems. Once they say, I can only walk about a block, then you can ask why. Risk factors for peripheral artery disease include age over 55, okay. Diabetes, smoking is an important one. We're going to talk more about that. Hyperlipidemia, and other identified cardiovascular risk factors or the presence of cardiovascular disease. The diagnosis can be confirmed with physical examination. So it's important to characterize the severity of the symptoms and categorize the patients. Again, this is by history and physical. And the treatment priorities are established once you make the correct diagnosis. And if you're in the outcomes business, you need to have outcomes data that can be stratified by a correct diagnosis and the type of treatment. But the thing I want to emphasize to the students and to our residents and anyone else who will listen is it's important to examine the affected part. If you don't look at the feet, if you don't look at the limbs, you're unlikely to make the correct diagnosis. Now, objective information is helpful to support the diagnosis, and the best way to do this is with a measurement of the blood pressure at the level of the ankle, and then measure the index between the arm pressure, the ankle pressure and the arm pressure. Okay. We measure blood pressure all the time in the hospital, maybe 4 times a day at patients who are perfectly normotensive. But we often don't measure the blood pressure once in a patient who presents with a limb problem. So it's important to measure the ankle brachial index. What you do at the bedside, in the ward, in the clinic, in the ICU, is the same as what's done in the vascular laboratory. A blood pressure cuff, a flow detector, and measurement of systolic pressure. It's part of a physical examination according to Medicare, because they don't reimburse it as a special procedure when you do it. But it provides important physiologic information that complements the anatomic information. It tells you how severe the problem is. The numbers are pretty simple to interpret. If the ratio of the ankle pressure is high, it's higher than the arm pressure significantly, that's an artifact. It's because the vessels are not compressible. Normal is about 1 or a little above. And the current guidelines suggest that we should call it borderline if it's in the 0.9 to 1 range. But the abnormal values below 0.9 define with high specificity the presence of peripheral artery disease. And this is what's often used in natural history studies to identify PAD patients. Now, diabetes is an important risk factor for peripheral artery disease, and patients with diabetes have about twice the prevalence of peripheral artery disease as non-diabetics. With diabetes and with a few other conditions, for example, renal failure, patients can develop calcifications within the artery that can make them non-compressible and can interfere with this simple measurement. So with non-compressible vessels, an alternative that we use in the vascular laboratory is a measurement of toe pressure. It's a way of getting the same physiologic information in the presence of calcified tibial vessels. The ankle brachial index is an important predictor of mortality. The more severe your PAD, the more likely you are to have mortality over the upcoming 5 years. So if you look here, these are 3 different curves for 3 different levels of abnormal ankle brachial index. And this association between ankle brachial index, which was identified there 2 decades ago, has been confirmed with more recent studies. And not only is a low ankle brachial index a risk factor, but a high ankle brachial index. So that's a marker for patients with diabetes or renal failure who have calcified arteries. So the presence of this arterial disease predicts your risk. And it turns out that it's not just those patients with symptoms, but even if you have PAD without symptoms, your risk of myocardial infarction or death is significantly increased. It's a little bit higher if you're symptomatic than if you're asymptomatic, but PAD as a diagnosis is a marker for risk of cardiovascular mortality and death, morbidity and death. Who should have their ankle brachial index measured? Well, there are guidelines, and it's probably reasonable to know that if someone has symptoms of arterial insufficiency, including claudication or a wound on the limb, they should have an ankle brachial index measured. Older patients, because of a 20% prevalence in those over 70, should have an ankle brachial index measured. And those over the age of 50 with a history of smoking or diabetes, or any diabetic patient with multiple risk factors. Making the diagnosis, we can categorize the severity of disease, and there are a series of categories that we will use. You may see in the chart, Rutherford grade something or other. These are categories that have been assigned to different levels of arterial disease that reflect the severity of disease, and it drives our decision making. Category 0 is simply they have presence of arterial disease identified but no symptoms. And then categories 1, 2, and 3 are mild, moderate, and severe claudication. But what I'm going to focus on a little bit more is what we focus on in our practice is critical limb ischemia, which is peripheral artery disease that's expected to require an amputation within the next year or so in the absence of something to improve the hemodynamics. Categories of chronic limb ischemia that incorporate this diagnosis, critical limb ischemia, include categories 4, 5, and 6, which are the presence of ischemic resting pain, the presence of some minor tissue loss, such as focal gangrene or ulceration, or extensive tissue loss, category 6. These are all clinical diagnoses, and they can be established by physical examination. But a physical examination isn't always straightforward in the modern world, because here's a case was sent to me by one of our graduates of the program, a general surgery program from last year, and she said in her hospital, a 78-year-old man was sent to the hospital ER by a podiatrist. He's a diabetic, former smoker, had a recent MI. He was admitted to the medicine service with this diagnosis of cellulitis, and the chart said, physical examination, ulcer with granulation tissue and good cap refill and palpable pulses. Not so bad. Now, there was surgical consultation requested. The call came in at about 11 o'clock at night, about 12 hours after the patient arrived. And it came after the x-rays were done that showed soft tissue gas. It turns out the patient had multiple prior operations, hospital across town, multiple prior endovascular procedures and partial foot amputation, and had come in with a white blood cell count of 33,000. So this wasn't cellulitis. This is gangrene in a patient who had no granulation tissue, had dead tissue, had gangrene, and no palpable pulses. It had been seen by a vascular surgeon a few months prior and had that confirmed, and had low ankle brachial indices. So there's really not a lot you can do without a certain amount of clinical acumen. You have to be able to suspect or diagnose PAD on the basis of risk factors, symptoms, or prior vascular disease. The physical examination, if done properly, can make the diagnosis, and the ABI is confirmatory. But an incomplete or an inaccurate physical examination is probably the biggest impediment to appropriate care. There's a growing problem across the world. There's a recent review of PAD prevalence in community-based studies using the ABI value of less than 0.9 as the definition of PAD. This looked at prevalence rates in high-income countries and in low and medium-income countries around the world. The data from 34 studies in both high and low and medium-income countries with over 100,000 participants found that there about 70% of the patients with PAD live in low and medium-income countries, including about 55 million people in Southeast Asia and about 46 million in the Western Pacific region. Over the decade, between 2000 and 2010, PAD prevalence increased by about almost 30% in these low and middle income countries, with sex-specific prevalence rates increasing with age. And smoking was probably the most important risk factor, because there was an odds ratio, meta-odds ratio for current smoking of 2.7 for the prevalence of PAD. We know from World Health Organization data that smoking is increasing, and its tobacco use is increasing around the world. And this is a graphic from the World Health Organization Tobacco Atlas. Cites kind of the old school, that was popular here in the United States decades ago, but is popular around the world now with the increasing use of cigarettes. 15 billion cigarettes smoked worldwide every day, okay? And it turns out that this is an asymptotically approach. I mean, at this rate, we're going to be an infinite number in 10 years. But the Chinese are leading here. It turns out that 1 in 3 cigarettes smoked in the world today are smoked in China. This graphic shows the prevalence of smoking in the population for men and women. And it turns out that in China, in that top one, on the, let's see if I can make this pointer. So here, this is the Chinese male population, Chinese female population. These are Chinese men who smoke and Chinese women who smoke. There are more smokers in China than there are people in the United States. The World Health Organization has responded, and there is a WHO Framework Convention on Tobacco Control that was signed into international law about 10 years ago, evidence-based treaty that provides some legal basis for international health cooperation and sets compliance standards. And it's one of the most widely embraced treaties in UN history, with 180 signatories covering 90% of the world's population. They have responded with measures to improve health and reduce tobacco use, what they call MPOWER, and I found that I needed to use some type of acronym based on the vascular surgery grand rounds from last month. So this is my acronym, MPOWER: monitor tobacco use and implement prevention policies, protect people from tobacco use, offer help to quit tobacco use, warn about the dangers of tobacco, enforce bans on tobacco advertising, promotion, and sponsorship, and raise taxes on tobacco. Taxes on tobacco products are used to fund tobacco control programs, but it turns out that tobacco tax revenues are used for other expenditures as well. You might perhaps use the ratio of taxes collected on tobacco control for either tobacco reduction or other goals to see how committed governments are to tobacco control. Here are the numbers. Governments annually collect more than $167 billion in tobacco tax revenues. They spend there's 167 in, less than $1 billion out on tobacco control. So here's what they take in. This is what they take out in high-income countries, in middle-income countries, and in low-income countries. So the majority of tobacco taxes are not used for health measures or tobacco use control. What can you do? Well, you're not going to stop smoking in China, but you might stop smoking in your patients. There are things that you can do, including ask patients and advise them. You can refer to the quit line. You can provide medications, and there are patient resources. If you're interested in helping patients with smoking cessation, and you should be, there's provider training available through the UC Quits program. So a couple of key points here. PAD prevalence reflects patterns of tobacco use. Smoking cessation is a primary therapy, and it decreases all-cause mortality in this patient population, and it improves vascular-specific outcomes, both the patients who are being treated with revascularization and those who are not. Smoking cessation should be a continued public health priority, but also an individual focus on with your patients. What can be done to treat the symptoms? Well, it's been known for a long time that exercise training is particularly effective. Here's a meta-analysis of 21 studies published 20 years ago. Onset of claudication, how far someone walks on a treadmill before symptoms, and maximal claudication pain, how far they walk before they have to stop. And patients who are treated with a supervised exercise program, here shown in yellow, have a marked improvement in their walking distance and their overall functional performance compared to patients who are not exercised. The question of supervised versus non-supervised exercise programs has been a contentious issue for a long time. In a Cochrane review from 2013, they looked at 14 studies involving over 1,000 patients with supervised exercise program, and they found that supervised exercise programs was better than non-supervised programs, but there was still some benefit from non-supervised exercise programs. So the recommendations to patients to walk and giving them a structure on how to exercise is important. But why don't we give them supervised exercise programs? Why don't we do what's been shown to substantially improve walking performance, putting them into a peripheral artery disease rehab program the same way we put in post-cardiac patients into a rehab program? Well, one reason. It's not paid. It's not reimbursed by most payers, including Medicare. There are a variety of approaches that people have used to try to improve compliance with home exercise. And there have been studies now using pedometer monitored exercise and a simple activity monitor that can be worn with wireless data recording. It turns out that home exercise program with supervision using the technology of remote sensing is actually pretty good and pretty close to supervised exercise in helping people become more ambulatory in the community and have better functional outcomes. Medical therapy does help some. There's only one medication FDA approved that's been shown in multiple clinical trials to improve walking distance and walking performance in patients with claudication. That's cilostazol, but it does have some side effects and it doesn't work for everybody. There are some other things that are an important part of medical management, including the use of statins. And there's level 1A evidence and strong recommendations for the use of statins, not only to decrease lipid levels, but to promote plaque stability by improving endothelial function and decreasing inflammation in the blood vessel wall. Use of statin in PAD patients significantly decreases all-cause mortality, cardiac death, irrespective of the patient's cholesterol level. And there is about a 22% reduction in major vascular events. Patients who are revascularized have improved graft and stent patency and decreased perioperative complications. But how are we doing? There was a 2010 study, the REACH registry, 45,000 enrolled patients with artery disease followed for 4 years. It turns out that when they looked at the patients who were enrolled on the basis of a PAD diagnosis, only about half of them were on a statin. It was better if they had coronary disease and PAD because doctors recognized if they had heart disease, they'd benefit from a statin. But the same benefit is seen in patients with statin use. And we're only seeing about 50% in these large studies, patients getting treated with the appropriate medications. So key points here are that there are widely available therapies, including exercise and medical therapy, that are underused, provide benefit, and part of the problem is the lack of appropriate incentives or reimbursement. All patients should have medical therapy prior to elective revascularization, and that therapy should include an antiplatelet medication, statin. They should have appropriate blood pressure control, and diabetics should have good glycemic control. Now, in terms of intervention, I'm going to talk mostly about critical limb ischemia. Critical limb ischemia is that most severe category where without revascularization, limb loss is the risk. And there's no effective medical therapy for this. Open surgical bypass was historically the gold standard with good limb salvage rates and durability, but the outcomes are affected by the quality of the available bypass conduit, the severity of the disease at presentation, and the extent of the obstruction. But I'll show you a couple of cases by way of examples. And none of these are brand new cases. Here's a 76-year-old man came in with toe gangrene, diabetes, hypertension in his history. He had a palpable pulse in the groin, but absent pulses in the foot, and very low pressures. Here's the arteriogram. Here's an example of an arteriogram that shows occlusion of the superficial femoral artery and the popliteal artery. And the tibial arteries are occluded proximally, but in the mid and distal calf, the perineal, a single vessel, reconstitutes from collaterals. Now, if you see, that's the blood flow to the foot, but then the arteries in the foot, the dorsalis pedis artery is present, the plantar artery is present. Well, this is a patient who underwent a long bypass, a bypass from the groin to the foot, which is actually not uncommon. This was used with an in situ technique. We operate and use the ultrasound in the operating room to confirm the technical result, and he was able to undergo amputation of the gangrenous part and preserved a functional foot. And we follow these patients after the procedure, and here's a duplex scan from about 7 months out that shows continued graft patency, and this patient did well in the long term. The limits, there are some limits that we need to think about with surgical revascularization. First of all, this is a population that has a relatively poor 5-year survival. About 50% are dead within 5 years. And so surgery or revascularization strategies need to be considered palliative in this significantly diseased cohort. There are functional impacts of surgical complications. One of the leaders in vascular surgery from the past was able to recognize that even though he had been a big advocate for surgical revascularization of the limb, he said what we have discovered with limb salvage surgery is what we could do. Now it's time to learn what we should do. Over the last decade, we've seen widespread adoption of endovascular techniques with increased utilization for patients with critical limb ischemia. And these have done very well at preserving limbs. We've decreased peri-procedural morbidity and mortality compared to surgery. But there are still some unanswered questions about durability, cost, and very specifically, case selection. Who should be treated with what? And the decision to recommend surgery or an endovascular approach differs quite significantly between providers, depending on the disease pattern of the patient, the availability of conduit. But really, the physician experience and training is probably a big one. It turns out that in this hospital, if you're a cardiologist, you almost never recommend bypass as the option for revascularization. And so these patterns by specialty reflect different patterns both within institutions and regions. give you an example of something that I thought is unique to endovascular approaches. Saw a patient who came in with diabetes neuropathy, peripheral artery disease, who had a non-healing ulcer on his great toe despite good local care. What we found was he had non-invasive studies, that showed that he had actually fairly good blood flow down to the calf level, but at the foot, the affected foot, he had very low perfusion pressures, and this matched up to the arteriogram. The arteriogram shows a widely patent femoral artery in the thigh. He had patent popliteal artery, but when we got down to the foot, all the arteries here were interrupted, and there was no blood flow through the arteries down to the level of the foot. This isn't something we can bypass. These would be bypasses through these little tiny vessels, but we can get small wires through there, and even with these very small vessels in the foot, do angioplasty with balloons of 1.5 to 2.5 millimeters in diameter, and reestablish flow and reperfuse the foot, and this man was able to heal his wounds. So this is a strategy that wouldn't have been possible with surgical treatment. And we saw this man in follow-up, and he was continuing to do well with patent endovascular revascularization. So there have been a lot of advances in peripheral intervention. Most of the things that we use now didn't exist when we started our endovascular program here a little bit more than a decade ago. A variety of recanalization techniques and a variety of new therapies. Angioplasty, the balloon dilatation of the vessel. We have a variety of better balloons to control vessel wall disruption and reduce dissection and reduce restenosis when we do angioplasty. We have sizes and lengths and features that are specific to peripheral applications, and we can get down to these very small vessels in the calf and foot. We use a variety of stents as scaffolds to prevent recoil after angioplasty and hold the blood vessel wall open. They can be balloon expandable or self-expanding stents, and there's a variety of different designs. And now we're starting to see drug-coated stents available for peripheral use. These are used to inhibit restenosis, and we have drug-eluting stents for superficial femoral artery applications, and now drug-coated balloons for femoral popliteal use. Crossing these difficult occlusions used to be something that if you couldn't get across, you couldn't treat, and so that was a barrier. But there's a variety of occlusion crossing tools, either a mechanical device or laser, to create a channel through a chronically occluded segment. If we cross and are subintimal, there are devices to get a guide wire back into the lumen of the vessel that allows angioplasty and stenting. And a simple thing like a guide wire comes in lots of different kinds of flavors, and there may be a variety of wires that we will use for different purposes. And it turns out with just simple wire and catheter techniques, most of the occlusions that we encounter, we can cross and treat. Atherectomy is a term that not everyone may be familiar with. This is the removal of plaque with some type of mechanical or laser device in the vessel. Sometimes it's been described as a strategy for debulking a lesion prior to stenting. It's now, there's a term lesion prep that is in vogue. It implies that you can do something to modify plaque to make it more treatable with angioplasty, including angioplasty with a drug-coated balloon. And sometimes it's used as definitive therapy. But atherectomy, the data from comparative trials is lacking. We don't really know if it's an improvement in general for patients with PAD, though I do use it for specific reasons. But the current use may be cost-driven because it reimburses more to do atherectomy, especially if you are in an outpatient setting. There are some complications to grinding up plaque in the bloodstream with the heart beating, and one of the complications is bits of debris can go downstream, and sometimes we can put a small filter downstream and capture material from atherectomy and retrieve that before it embolizes. But sometimes we can't. And here's an example of a patient who has multiple petechiae on the leg. These are atheroemboli after rotational atherectomy in a tibial artery. I'll give you an example of a case of someone who came in with focal gangrene of the toes, He had severe ischemia, had diabetes, and a former smoker. He'd already lost his other leg, and he didn't have any options for revascularization. He had multiple segments of severely calcified plaque and stenoses and an occlusion of the anterior tibial artery. He underwent atherectomy and a subsequent angioplasty, and then had actually a pretty nice result. But one of the problems he had is downstream occlusion. Some of his debris went downstream, and the anterior tibial and perineal arteries were occluded. He had reconstitution of the posterior tibial artery in the calf because of his non-healing wounds and worsening of his foot ischemia. He was able to undergo bypass with a prosthetic graft, and that allowed successful salvage. But this is a case where he was actually made worse by the endovascular strategy. We like to avoid risks that burn bridges, and embolization is one of those risks, but occlusion of the outflow artery that could be used as a target for a bypass graft is something that we want to avoid as well. Here's a patient who was referred to us for treatment after he was seen by another provider in the north part of the valley, and he had a whole series of stents put in his posterior tibial artery, permanently occluding it, and we really lost the opportunity for a simple tibial bypass because of that. So there are a wide range of technical options available for revascularization. I think it's advantageous for us as surgeons to be able to select treatments based on individual anatomy, presentation, and tailor the treatment to the individual. There's been a big shift from open surgery to endovascular, but really limited decision-making support tools to allow us to know who really should have what therapy. Comparative effectiveness data have been published. This article in Circulation from last year, Dr. Hediati, one of the co-authors, analyzed large registries from Kaiser in California and Colorado and found interventions were actually fairly successful at lowering early complication rates, but repeat procedures were more commonly required after endovascular treatment. And importantly, for critical limb ischemia, there's no difference in amputation rates. This study from 2010 shows that there really have been some dramatic shifts in how patients have been treated with different strategies for peripheral artery disease. Here on the left, patients with intermittent claudication, you can see a substantial decline in lower extremity open surgical revascularization and a substantial increase in endovascular. And so this really represents a changing paradigm in the treatment of patients with arterial occlusive disease. If you look at patients with critical limb ischemia, you see declining rates of amputation and open surgery, declining rates of open surgery, and increasing rates of endovascular. What we've seen is we've been able to make improvements overall in outcomes. But despite this, it's hard to know exactly how to choose specific treatments or where to do them and how to do it in a cost-effective way. In 2008, Medicare modified their reimbursement rates to encourage more patients to be treated in the outpatient setting, and they changed the reimbursement on different procedures. What we saw in the last decade as a result of that is rates of intervention not really changing a lot. Patients are being treated about the same amount, but the clinical setting has been shifted to the outpatient basis. And the reason for this is largely driven by atherectomy. Twofold increase in outpatient hospital setting use, like our cath lab, because there's not a lot of economic incentive. But if you have an office-based practice, you get paid more for doing atherectomy. So there's been a 50-fold increase. So I'm not saying that atherectomy is bad, but I'm saying that there certainly seems to be economic drivers, and the increased use of that particular technique in outpatient facilities really neutralize the planned cost savings. This shows the rise in office-based practice and outpatient practice. So hospital inpatients decreasingly treated more outpatient and hospital, or excuse me, and office-based therapy. Let's see if it turns out that the economic drivers for change that move practice into settings where there's less oversight and perhaps financial incentives for specific types of treatment have become hot button issues in our specialty. And at our annual meeting, the Society's president in 2015 addressed this. He has cited an article in the New York Times from a year ago that discussed some of the problems with high costs of peripheral artery interventions. And that included a report of one physician who collected $18 million in 1 year from Medicare, with $13 million for performing lower extremity arterial interventions. This is someone who doesn't sleep. So there are some outliers that are dramatic, but it highlights the need to create accreditation systems for establishing quality standards for all types of procedures, including office-based procedures. And it's been proposed that reimbursement for high level of care should be linked to appropriate certification and expertise. Reimbursement for simple, low risk, and effective strategies should be mandatory, like a walking program or medical therapy, before authorizing expensive interventional procedures. And perhaps paying for some elective procedures over time so you can see the results might have some benefit. Well, right now we're involved in a trial, the BEST endovascular versus BEST surgical therapy trial for critical limb ischemia, which is a multi-center study, NIH supported, to evaluate the effectiveness of the best available surgical therapy or the best available endovascular therapy in adults with critical limb ischemia who could be treated with both treatment options. And this is a randomized study to either open or endovascular treatment with follow-up for several years, outcomes to be compared within 2 cohorts, including those with and without a good piece of saphenous vein as a bypass conduit. And it compares really any technique for open surgical revascularization that the surgeon wants to use to any endovascular revascularization procedure with an FDA-approved device. We'll see primary outcome and secondary outcome measures, but the primary outcome measures will be the major adverse limb events, like did something happen bad with a leg, like an amputation, or death, and a variety of secondary outcome measures like functional performance. We're also involved in the Vascular Quality Initiative, which is a large registry and outcomes database for vascular disease, sponsored and supported by the Society for Vascular Surgery, but also by the Society for Vascular Medicine and the American Venous Forum. At UC Davis, we're participating in many of the modules of the Vascular Quality Initiative, or VQI, but not yet fully in the CLI and peripheral artery interventions. We need this kind of data to move forward and make good choices. So what are the impediments to improving care? Well, if you don't see it, you can't treat it. You have to look. You have to recognize the presence of the disease, and you have to understand the presence of available therapies and use them appropriately. To summarize, if you're a student, well, understand PAD is common. It's associated with cardiovascular risk factors. It's going to be under-recognized. You're not going to see it unless you look. So you have to take a history and ask how far can you walk. You have to do a physical examination that involves removal of the socks. And you have to know how to measure blood pressure. If you are a provider, you need to know that for the most part, patients with peripheral artery disease benefit from appropriate medical management, and revascularization is appropriate for claudication in selected circumstances. But for patients with critical limb ischemia, it is the preferred option. And if you're a specialist, you need to have a better understanding that new interventional technologies have created many pathways for patient care. The decision-making is seldom supported by the availability of level 1 data. And you have to be a bit skeptical because the value for specific technologies remains unproven. We think it's going to be increasingly important over time to monitor outcomes to determine what are the best choices. So the world has changed. We used to have kind of a simple view of the world of bypass for everybody, or someone else might say endovascular only. But I think the best way to approach this is with a multifaceted, multi-tool approach that includes behavioral changes, medications, endovascular, and surgical treatments. So that's what I've got for you today. Thanks for coming. I'd be happy to take any questions for those who don't have to work today. Yes, ma'am.
First of all, thank you. That's a great overview and a really nice update of sort of where we are. The one thing I wondered about is that I've seen the stem cell trial being advertised in peripheral vascular disease here at UC Davis, and I was just wondering kind of what that's all about.
Questions about the availability of stem cell therapies. Stem cell therapies are being used in clinical trials for a couple of different things, but here primarily for patients who don't have revascularization options, either endovascular or open. So for no option CLI, critical limb ischemia, there have been some options available. The number of trials that have showed significant benefit is pretty small, rounded to the nearest whole number. This is an area for which there has been public enthusiasm and enthusiasm in the medical community, but that enthusiasm has not been driven by data as much as it has by the potential for benefit. It's too early to say yes or no, but it would be a stem cell therapy at the current time would be an option for a selected number of patients who have no other options with established therapies. I don't think it's going to be a game changer in the short term.
Yeah, I've seen the advertisement from out of UC Davis, which is what made me curious.
Mm-hmm.
The woman who is on TV at the moment that says she can walk again, and I thought,
There are absolutely anecdotal reports of success, and there are some small series that show some success. One of the problems is looking at that with an appropriate control group, and we have been involved in trials that have included a sham treatment arm for control. It's very difficult because the natural history of small wounds is often related to the level of care provided, not just the substrate. So patients who come in for regular wound care and regular physician visits often do well when these are the same patients who would do very poorly with poor self-care.
Again, the importance of trials.
Yeah, I don't think it can be. I don't think you can say anything until you have data, and so it's very common for me as a vascular specialist to have someone come in and bring in a product and say, "What do you think? Would you try this?" And I say, "Well, I think it's a great idea. Would you try it? Maybe. Do you think it's a good thing?" I can't say because I don't have the data, and I think that it's very important that we gather data. The problem is we don't really have a system of care that allows us to get those data very easily. I would love to see a situation where you got paid 70% of what Medicare is going to pay you for what you did, and 30% for giving data down the road about how it turned out. Even if it didn't turn out well, just say we'll pay you a little bit extra. We'll pay you 120% of what we would pay otherwise to get data at 6 and 12 months. Because then if I'm Medicare or I'm the taxpayer, I guess which I am, I could say after a certain amount of time that this was worth paying for or not worth paying for, but we don't collect data that way. Yes, sir.
So in the series of vascular talks recently, what's apparent is obviously that there's a lot more sophistication about getting at blockages in vessels, things that you showed. But I think those vessels, right, are fundamentally diseased at some point. So where are we with being able to change the disease progression in the vessels? Because it's very curious.
Yeah, so the question is really, how do we change the disease? And part of the focus is changing the patient's lifestyle. So that smoking cessation actually changes the disease. It changes the vascular biology. The use of statins appropriately in patients through a perioperative period and postoperatively actually changes outcomes. It changes how the blood vessel responds. And now anti-proliferative strategies like a paclitaxel-coated balloon that's a chemotherapeutic agent delivered to the blood vessel wall at the time of the intervention reduces that proliferative response. So we are manipulating the biology. And what you can expect to see in the future are different types of devices that deliver either a drug or a biologic therapy. For example, a stent that goes in that dissolves over time, a bioabsorbable scaffold that's used primarily as a drug delivery tool or delivery tool for biologics. So these are things that are being looked at. Now remember that every therapy that's ever been discarded in any part of surgery or medicine was at one time a great idea. So the Department of Good Ideas generates lots of stuff, and we have to sort through it. And we're doing that, and we're making progress. And so we see, compared to 10 years ago, lower peri-procedural morbidity and mortality rates, better limb salvage rates, better focus on functional outcomes for patients, and in many arenas, I think more cost-effective care that focuses on well-being, not necessarily just the patency of a bypass. So we really are doing a lot better in many, many ways. But as we do that, it does get more complex, and we have to be critical or critically examine our own outcomes to be able to figure out what to do next. Thanks very much.